Brenner Williams, welcome to More Health, Less Healthcare. And my appreciation for just an excellent case study in the Health Equity Case Studies Handbook. It's just a terrific example of SDOH in action. So I've been looking forward to meeting you for a number of months. So I was curious, you're a physician by background
I am.
and a physician and an entrepreneur. So tell us more about your background and how did this lead to socially determined?
Sure. First of all, thank you. Really appreciative of what you're doing and how you are shining a thoughtful and bright light on this topic. And thanks for
Hopefully.
yeah. Appreciate you allowing me to participate in the conversation. Yes, I'm a doc. I grew up in southwestern Virginia. I went to medical school at Marshall in West Virginia, which one of the smallest schools in the country, very primary care focused. I had the opportunity to do a lot of my training in a community health center, both in Huntington and other parts of the state. And you learn a lot about people and the lives that they lead in community health centers. Arguably,
I'll
one of
bet.
the
Yeah.
best places from a clinical standpoint to connect to individuals and their families and the community as part of that. I did my residency in Los Angeles at Kaiser Permanente, and this was like
Oh,
late 90s to 2001. It was an interesting, HMOs at that time, a very interesting sort of look at those organizations. I loved, though, this opportunity where both the reimbursement and payment of healthcare was directly tied to the clinical delivery of care. And frankly, in medical school and traditional schools, I don't think you get a fair amount of that exposure. And so it was super helpful as part of that. It was also, the time of the dot-com bubble and burst. And so there was in Southern California, in California in general, there was a lot of entrepreneurship that was happening. I got caught up a little in that in a good way, started a dot-com while I was in residency,
oh,
that failed quickly, but was really interesting just to get exposed to that and also started to get much more involved in what was happening with digital health in the space, early days. And when I became medical director at a critical access hospital in the Sierra Nevadas in Northern California, I had the opportunity to lead their selection for an electronic health record. And it
oh.
was down to Dairyland versus Meditech, which was there were limited choices for small little hospitals like us as part of that. Um, and I realized how important, or at least how important I thought, having physicians, clinicians at the table during those important decisions, and how we were thinking about the opportunity and the hope of bringing patient level, community level insights directly into clinical care, right? And to be able to
Right.
have the ability to share that data broadly across the healthcare ecosystem. And I loved it so much. I actually left full-time practice. I joined the Navy as a lieutenant in the reserves, but left full-time practice in January of 2003, joined a consulting firm, and got to help Kaiser roll out Epic,
Oh
both.
my, yeah.
Yeah.
You're,
Yeah,
and you survived.
I did. And it
Yeah.
was, it was fast. I mean, at the time, still, it's one of the largest EHR design and then deployments
Hmm.
in the country, certainly. I spent a year and a half there, and then my wife and I got married, and we moved to London to support the National Health Service and what was going on with their national program for IT as they were building one integrated record for the entire country. Fascinating experience. When IBM bought that company a year later, I came back to the US and eventually founded a consulting firm called Clinovations, primarily focused on electronic health record optimization from a clinical point of view. So half of our 300 consultants were physicians. So a very different take on the sort of clinical workflow. And we were fortunate that company we sold to the advisory board company in 2014. Finally, getting to your question about socially determined. So much of the work that we were doing was around risk adjustment, especially in the Medicare Advantage space. And still, but certainly back then, almost all of the calculations to determine risk were calculated based on clinical acuity. right? And not taking into account the barriers, obstacles, or the support systems that an individual had in their life. And it seemed like we were missing something. And there were sort of two primary drivers that led to me for socially determined, maybe three. One was we had the chance at Clinovations, my old company, to work with the VA and help build a model for non-traditional determinants of health or social determinants of health. This was back in 2012.
Mhm.
Second opportunity was working with a cardiologist at Duke who was working on a CHF in the home program and the ability to keep people out of the hospital. It was all predicated based on social risk, right? And whether that person could do well. And the third, and probably the most important, the reason that I'm a family doctor is my mom was a social worker. So she was the executive director of the local office on aging in Southwestern Virginia for 32 years. And I remember in 2015, I sold my company. I'm still at the advisory board who bought that company and talking about what was next for me. And she was talking about how her social workers, when somebody was eligible for Meals on Wheels in Southwestern Virginia, a social worker would go to their house and perform an in-home assessment, right? And they're looking in their refrigerator, in their pantry, and seeing what's going on in somebody's life. And they knew more about that person, right? And again, the barriers and obstacles that they were facing than I ever did as their doctor.
Yeah.
So, sort of step back with all of these experiences and said, there has to be a better, more inclusive way to think about risk and risk insights. And if you're taking
Mhm.
financial risk on a person, don't you want to know as much as you possibly can about those individuals and seeing the opportunity, again, from my mom's point of view, this chance to understand, again, what people were going through and thinking about how to connect people with high needs with solutions that might actually help mitigate their risk and allow them to have better outcomes. And so in late 2016, early 2017, Socially Determined was born as part of that.
Well, let me key back to quantifying social risk.
Yeah.
All right, so what's the relationship between quantifying social risk and social determinants of health? How does this one leads to the other?
Yeah, so we think a lot and we talk a lot, and I believe understanding both risk and need, Peter,
Yeah.
are really important. And I think most of the time when we're talking about social determinants of health, or now another term, health-related social needs, right?
Yeah.
We're talking about somebody generally in active crisis, right? Whether challenges with their housing situation, or maybe they don't have enough food to feed their family at the end of the month when their SNAP benefits have run out. And that's an active need. What we do at Socially Determined at scale is try to better identify and characterize the risks that a full population has, all the way down to a person level as part of that. I want to use an example and then I'll come back. I'll use a clinical example. So I think about cardiac risk. So I'm a 55-year-old white male with a family history of cardiac disease. I'm a little bit heavier than I'd like to be, and my diet isn't as great as it probably should be. I have cardiac risk. I'm fortunate I've not had a cardiac event at this point, right? I haven't had a need, right, for specific intervention as part of that, like to have a stent placed or surgery or anything else as part of that. But I still have risk. Just because I haven't had a need does not mean that I don't have true cardiac
Sure.
risk. We think about social risk and social needs in the same way. So think about food insecurity. And we can say with great confidence, based on where somebody lives and how far away they are from a full service grocery store or a convenience store that may have take SNAP benefits as part of that, that they don't have great access, right, to healthy food options. We can say because of their household income, how much they pay for housing, that they may, and how many people they have to feed in their house, that they may have real risk associated with feeding and affording to be able to pay for healthy food for their family as part of that. We may say because of education levels, language spoken, other things like that, food literacy, the ability to shop, cook, plan, etc., may be challenging at that person level as part of that. So they may have real risk, and we're able with confidence to identify that risk. That person likely over the course of days, weeks, months, and years goes into, they always have risk, but their need vacillates, right, over time.
Right. Right.
And we think it's really important. One, if we understand risk on the front end, then health plans, health systems, organizations can be more proactive about addressing those people with high risk, whether they have a need right now or not, and ideally preventing them, mitigating risk before it transpires into crisis and high need.
Common sense,
Yeah.
applied common sense.
Applied common sense. Yes,
Well,
sir.
and you also use a phrase in your executive interview that analyze first.
Yeah.
It seems self-evident, but apparently it's not. So what do you mean by analyze first? You're really talking much, much wider scope than the industry is used to looking at.
Yeah, I think for lots of reasons, and I don't mean this in a pejorative way, like, but most of healthcare is very reactive,
Yeah.
right? As somebody walks in our door, whether that's in a clinic, it's in an emergency room, they get admitted to the hospital. Like we're we are as a country great at delivering sick care in a reactive way and addressing somebody right in front of us. For lots of reasons, including financial reimbursement and others, we haven't historically been great at being proactive about that.
Yeah.
And so our strategy, sort of around the central thesis, Peter, that no customer or partner of ours has infinite resources, money, people, or time. Um, it means that they have to be thoughtful, precise, focused with where they spend that money and time and those resources as part of that. So our belief is ideally you start to look at an entire population of maybe hundreds of thousands, maybe millions of people at a time. You can't do everything for everybody then. So you have to get really smart about what you can do and then who you should do that for. And so our belief in terms of analyzing first is being able to look at a full population, characterize the risk of everybody, characterize that all the way down to an individual person level, where you think of them as a patient, a member, an employee, right, as part of that, all the way down to that person level, and start to identify those people. And I know I'm sure we'll talk about the link to healthcare data like disease and cost and
Right.
utilization. Thinking about social risk with healthcare data, I can start to identify cohorts of individuals that have both clinical risk and social risk, and likely have variation in sort of where they go for care, their utilization of care, the cost of care as part of that. And so the analyzing first allows organizations to be much more efficient, much more effective, and much more precise in what they do.
All right, so let's pick up on that.
Yeah,
Apply it to one of your key constituencies would be self-insured employers.
sure.
The other component is health plans. How would this apply to those two market segments?
And I would say that most of the work we support self-insured employers primarily still through the health plans or like a TPA, right,
Right,
as
right.
part of that. Let me just back up maybe 1 second on the employer space right now, because I think it's a really challenging time for employers as they are managing the healthcare costs, right, of their employees and their families. They are faced with rising premiums, and have been for years. They struggle, I would contend, with the value that they receive as part of those elevated premiums. And if you're an employer, you're also impacted by things like absenteeism, presenteeism, productivity, churn, right? So people leaving, hiring, all of those things for your employee base as well. We believe, and I think there's really great evidence that social risk contributes both to healthcare costs, but also all of these other
Yeah.
employer metrics. So what's been interesting for us, and Peter, I would say when we started the company, I wasn't maybe aware, wasn't thinking that the commercially insured individuals, self-insured or fully insured at the commercial level, would have significant social needs. And we weren't even thinking about those stakeholders as buyers, right? Partners, customers of ours when we started the company. And now in 2025, more than 50% of the lives that we touch and process are commercially insured,
Oh,
either self-insured or fully insured as part of that. And what's happened is employers have come to their health plans or to their TPAs and said, we've got to have more. You've got to help us. Going back to this idea of analyze first, we've got to be more precise. So how it works today, either with a TPA or with a health plan for a fully insured population, we receive a member roster. So it has just demographic information, so name and address, gender, date of birth, things like that. We'll get employer, so we know again who their employer is as
Right.
part of that. The reason that that becomes really important is when we run our analytics, we can then start to segment the population at an employer level. So now I can look at social risk of an employer. If you're a health plan or a TPA and you're managing lots of those employers, you can start to benchmark and compare employer by employer. So I can start to say that this employer has significantly greater food insecurity or transportation risk in their employee population. So the insights become the starting point. What they do with that information, both at an employer and at a health plan level, is the first thing you start to do is align high need employees with existing benefits. We don't do a great job of that today. And arguably, most of the individuals who take advantage of benefits that are available to them actually aren't the ones with the highest need, especially those that are like social interventions, say related to food or transportation or economics, financial opportunities as part of that. And so the first thing can be, how do I align those individuals, those employees with specific benefits that are available to them? And so we do that analytically, can help to do that matching. The next piece is based on the risk profile at the employer level, how employers start to think about their own benefit design. What are the needs that they need to have, right? Or their TPA or health plan that they're working with, actually designing and identifying new partners that help address those outstanding risks that those employees have, where they maybe haven't had a solution at all. And so for us, I think it becomes so important to support that employer community, partly because one of the most challenging things in healthcare is the lack of opportunity to engage an individual.
Yeah.
And health plans are on the farthest side away from that, right? If you think about your own care, I have very little interaction with my health plan as part of that. Most people don't. You know where you have the most interaction? If you're fully insured, like if you're part of a big employer, like at the employer, like you spend 40 hours, 50 hours a week, right, at that employer. There are thousands upon thousands of touch points and engagement opportunities. And thinking about where and how an employer, when they're interested in both curbing and bending the cost curve for their employees and addressing other employer metrics, they have this opportunity to start to be able to nudge and provide awareness around interventions that might be supportive.
Well, I imagine this tees up social scope. What is
So,
social
yeah,
scope and how does it relate to data collection,
yeah,
analysis, very
yeah.
specific intervention?
Yeah, so Socialscape is our platform. Um, and it's sort of think of this in two ways. It's the what nobody sees, it's the platform that allows us to combine publicly available data, licensed data about every US business in the country, and identified consumer commercial data on about 260 million adults across the United States and our customers' healthcare data. That could be cost, utilization, employer, provider attribution, quality measures as part of that. And the ability to integrate all that information together under one single analytic platform. And then we have so many applications and ways to visualize social risk at a community level and at a individual or population level as part of that. And so we built analytic models that allow us to characterize and quantify social risk for every community across the country down to a 200 meter, about a block level view. So much more granular than a census block or a census tract or a zip code for sure as part of that. And the ability to show risk, resources, and individuals, members, employees, patients, however, whatever lens you use to think of them, see those individuals on the map as part of that and do deep dives into what every community across the country looks like. And importantly, on that identified individual side, so if you're a health plan or a health system, being able to look at all of your patients and members and their social risk, we create a profile, Peter, of about 45 data elements per person, risk scores, drivers of risk, and other contextual information, all at that individual person level. So I can start to segment that population and start to identify those people where I want to have direct engagement, interaction as part of that.
It sounds overwhelming
It is.
what you do with all these data points.
Yep.
But when you're talking, Brenner, at the community level,
Yeah.
I mean, to me, it's a no-brainer. If you can't get to that level of granularity, I'm not sure what you really have to work with. What is it about much of the industry that doesn't really aggregate data from those kind of touch points? What's the disconnect here within the industry?
I think there are a couple of things. I think you use the word overwhelming, and I use it a lot in sort of how we think about this because one of the challenges I think across the industry is people haven't been sure what to do once they identify risk, community or
Right.
individual. And I think that lack of we talk about the what, the so what, and the now what. So if the
Yeah.
what
Yeah.
is understanding risk, the so what is that integration, ideally with healthcare data. The now it's like, what do I do about it? And I think there's general paralysis in the industry about the now what. And I think that stops people from even looking as part of that. The second piece is you start to get into whose responsibility or
Right.
who benefits from those type of investments as part of that employers. I think the reality is we all benefit, but most organizations, most individual organizations struggle with sort of footing the entire bill and the effort, knowing that will benefit them some, but also everybody else. It ideally takes this partnership that is payer, provider, government, right? All of
Mhm.
these things together, employer, those, especially those four stakeholders together. And I think it's just hard to align incentives, financial and other incentives for organizations.
I get a lot of feedback that there's a liability for identifying what the need is and
And then,
realizing you don't have the capacity, whether it's a lack of leadership, lack of resources, lack of
yep,
demand, you don't want to tee up what the need is and then not follow through on it.
right.
It's a conundrum that we really haven't solved yet. So I'm curious, when you look at, you have five main domains.
Yes.
Why not three? Why not seven? Why not 10?
Yeah.
What's the
Yeah.
magic about five?
There isn't magic. It's actually the reason and our sort of first principle is we believe that we needed to have enough robust, consistent, and national data to be
Okay.
able to calculate our risk scores for everybody in the countries. An example of that is like crime and violence, which we've been asked about a lot. That's a really important one, I think, to
Mhm.
understand. There's not a great national consistent data resource to be able to get that information, unfortunately. And so while we could get it consistently in some parts of the country, in some states, or maybe even in some counties, we couldn't get it for everywhere. So we didn't include that as part of our mix. We have five at an individual level. We have two additional ones at a community level, the digital landscape and social connectedness. So those are
Right.
in addition to the individual. Part of it also is bandwidth, like very transparently. Like I think we can develop more. I think like digital landscape, if I had to think about sort of in order, that's probably the next and easiest one to be able to think about where we might be able to do that at an individual level. Um, and then social connect is probably after that. The other thing that we think about is like we want that risk to be addressable. Sort of going back to our last part of the conversation, like you have to feel, especially for our healthcare stakeholders, that they can do something about that risk, right? That they can mitigate that risk with an intervention. It makes sense for them to invest time and energy and money. They have resources, partners, whether those are community or other vendors that can do that. It's partly why I think the digital landscape becomes the next one because you can start to think about different, right, digital health tools or telehealth options, right, to become part of that.
All right, so you've covered digital landscape, but you also just mentioned quickly social connectedness index.
Yeah.
What's that about, and how does that? There's a whole segment now becoming much more aware of impact of loneliness, lack of social
Yeah,
connection, empathy, et cetera. What's social connectedness, and how does that then feed back into all your other components?
sure. And again, transparently, I think this is one where we have an opportunity, more likely through a lot of our partnerships, to be able to help address, yes, this rising, again, I think visibility into the impact of loneliness as part of
Yeah.
that. For us, this is a pure community level metric as we think about the impact of social connectedness right around communities. We look a lot at family size as part of that. We look at the social network in a given community. We look at things like walkability. We look at park space and other. We look at civic organizations. So it's very community centric about the infrastructure, both
Okay.
real and people, as part of that. I think that's an important piece of the much broader social connectedness, where we do a lot of our day-to-day work with our customers and their other vendor partners, and would love to maybe dive into this with you in a second, is there are a number of really great vendors, I think, today that are helping to address social connectedness, loneliness,
Okay.
isolation as part of that. Rima, Pix, Wider Circle, and there are lots more, right, that are doing an amazing job in very different ways sometimes of helping health plans, health systems, government organizations identify and mitigate risk around and the impact of loneliness and social isolation as part of that. Where we have probably seen the greatest value that we can provide is our through either a health plan or a health system, our data on the front end to help characterize the social risk of a person and a population, and being able to deliver that data directly to these other vendors on behalf and with, again, the permission of the plan or the health system that we're working with, so that now as they're engaging those individuals, they've got all of our analytics and opportunities as they think about what additional needs those individuals might have. They can be much more prepared, much more efficient, much more effective in the outreach, engagement, and support that they provide.
I'm not sure I can comprehend all that in one bite, but you seem to be hinting at where's socially determined going to be going the next few years in terms of products, markets,
Yeah.
relationships.
I think a couple that make sense for us. One, we have continued to move down that what, so what, now what path,
Yeah.
where initially for the first number of years, Peter, we were only providing our analytics at a person and a community level. We then started to integrate our data, have our customers or work with partners like Medi Analytics, as an example, to integrate our data directly with healthcare data. So you can start to, like, I think if you want to get a holistic view, I don't want just social risk and I don't just want healthcare data. I want both and I want them together. So we could start to figure out where do you focus your efforts. And then the third was starting to build all these relationships, data sharing partnerships, and work with all these other vendors who are on the ground engaging, intervening. Where we're going and where I see us going, I don't think you can have a podcast in 2025 and not talk about AI as part of that.
Sure.
But predictive next best action
Yeah.
opportunities, right? To be able to tee up at a person level. And we're doing this today, I would say at small scale. We're doing it today, larger scale, like for populations. It is both a strategic tool to help organizations figure out where they invest and what types of partners they need. And at an individual level, being much more efficient and effective about, again, what those needs are and giving them the answer of the now what, which I think is super helpful. I think for us to so much of the not just disseminating information and insights, but being able to collect those insights directly from an individual, a family, and a community as part of that, as part of a feedback loop in terms of like what other information, just because they're at risk, can we help like if they're at greater need, how do we pull that in? So for us, I think getting closer on the ground to member, patient, employee as part of that, and using the AI that we currently deploy today at broader scale to provide more precise recommendations and next best actions.
Well, I think you pretty much summed up my last question, which is going to be crystal ball 4 or 5 years from now. And you're obviously an optimist on where this field is going, first and foremost. Where do you see it in 4 to 5 years?
What I'm hopeful about, and what I was hopeful about when we started this company, is I think for this work to truly be sustainable, it has to be integrated into our financial reimbursement models, right? Period.
Yeah,
Otherwise, it's too easy not to. For it to be integrated into our financial reimbursement models, the library and the collection of data around the return on investment,
yeah.
financial, experiential, outcome related, we've got to build all of that evidence out. And every day and every week and every month, there's more and more evidence. I think we have to, as a collective, and I love leading the way, but as a collective, I think we all have to be contributing to that evidence as part of that to make it so compelling and so obvious, right, that the return on investment is there broadly for all stakeholders as part of this, that it gets integrated into our financial reimbursement models. And it just becomes, again, I don't want social determinants and social risk as a side hustle on the side of somebody's desk. It's got to be all the way in and fully integrated, right, to make the real difference.
Well, PMPM does make a difference,
It
right?
does. Yeah.
And return on investment is not going to be just a quarterly review. It's going to be longer term.
Yeah.
But I think the landscape that you're looking towards makes a lot of sense. And I just hope that more people will read your case study, learn from it. And I've really enjoyed working with you the last couple of years. So
Thank you, Peter. Yeah, I have as well. We have as a company. So I really appreciate it as well.
thank you again.
Thank you, Peter.